Achha, Dr. Khatija is from Shifa International Hospital, Islamabad. She's going to talk on outcome of haploidentical hematopoietic stem cell transplant in resource limited settings. So our first.
Assalamu alaikum. My name is Dr. Khadija. I'm third year fellow in clinical hematology in Shifa International Hospital. And today I'm going to present the outcome of haploidentical hematopoietic stem cell transplant in our setup. So basically we did a retrospective observational study and we included all haploidentical transplant patients, which were done from 1st December 2016 to 28 Feb 2022. We used peripheral blood as a stem cell graft source in most of our cases, while we used as bone marrow stem cell graft source in only one of our cases. So donors were haploidentical siblings in most of our cases, and all transplants were done using GCSF mobilization of the donor with a median CD34 dose of 6.5 million cells per kg. All patients were giving prophylactic medications accordingly. The main conditioning regimens which we used were JSWAL protocols for acute leukemia, TBI-based regimens for aplastic anemia and acute leukemia, and GIOSO protocol for lymphoma patients. So the JSWAL protocol, which was used for hematopoietic stem cell transplantation of acute leukemia patient, it was based on fludarabine, busulfan, melphalan, and post-Cy. And post-Cy dose which we used is 40 mg per kg per day, but in the original protocol, it was 50 mg per kg per day. Second protocol which we used for as conditioning regimen was Lesnick protocol, and that was TBI-based regimens, and it was comprised of fludarabine, TBI, Cy, and post-Cy. The dose of TBI was 200 CGY. And the dose of Cy in post-Cy in original protocol was 50 mg per kg per day on day +3 and day +4 of transplant, while we used 40 mg per kg per day. So this is the another protocol which was also a TBI-based protocol. It was based on Discern study, which was published in 2018. And that protocol is based on flu, Cy, ATG, TBI, and post-Cy. Again, we used lesser dose of Cy as compared to the original dose. In this protocol, in the start, the TBI dose was 200 CGY, but later on it was increased to 400 CGY per day because there was increased risk of graft failure in the lesser dose of TBI. So this is the protocol which we use for stem cell transplant of Hodgkin lymphoma patients. These they were two patients which underwent haplotransplant in our institution after relapse from autologous transplant. This GIOSO protocol was based on fludarabine, busulfan, Cy, and post-Cy. So the primary outcome of our study was to determine overall survival, and the secondary outcome was to determine engraftment, relapse, progression-free survival, non-relapse mortality, transplant-related mortality, and acute and chronic graft versus host disease. This is a haplotransplant algorithm which we use in Shifa. So whenever we plan to plan haploidentical transplantation for any patient, we determine luminic screening of that patient. And if it is found to be negative, we proceed with the transplant. But if it is found to be positive, we proceed with donor-specific antibody testing by SAP testing. And if it is positive, and MFI, which is mean fluorescence intensity, is more than 1000, either we defer the patient or we proceed with the desensitization protocol, followed by monitoring of donor-specific antibodies. And if it is found to be negative, then we proceed with the transplant. So coming to the results of our study, majority of our patients fell into this age group of 20 to 40 years of age. Majority of our patients were male. Most of our patients had diagnosis of acute leukemia, followed by aplastic anemia, then CML, then Hodgkin lymphoma. So majority of our patients had normal cytogenetics, followed by complex cytogenetics in 5% of the cases, followed by translocation 821 and translocation 922 in each 3%. So FLT3 mutation was detected in 8% of our cases, MLL in 3%, JAK2 in 3%, and BCR-ABL in 3% of our patients. At the time of transplant, 50% of our patients were in CR1, while the rest were in CR2 or beyond. At the time of transplant, most of our patients had ECOG of 0 or 1, and the rest had ECOG of 2 or 3. So Illuminic screening was done, which was found to be negative in around 60% of our patients, while it was positive in 40% of our patients. Donor-specific antibody was not done in 60% of our patients due to some financial issues or other issues, and it was detected in 3% of our patients only. So the main conditioning regimen which we used were, because most of our patients were with acute leukemia, so the most common regimen which was used was JSWAL regimen, which was based on BU, flu, MEL, post-Cy, followed by TBI-based regimens, which I have already discussed. Around 75% of our patients were ABO compatible, while the 25% of our patients were ABO mismatched. So the median day of neutrophil engraftment was day 14, followed by platelet engraftment of day 15. Most of our patients achieved donor chimerism at day 100. So we also follow CMV infection in our patients in first 100 days of transplant by PCR, and it was detected, and more than 500 copies were detected in around 35% of our patients. So the cumulative incidence of grade 2 to 4 GVHD was around 30% in our patients, while it was around 55% in around 55% of our patients, either there was no GVHD or grade 1 GVHD. Out of those 31 patients, most of our patients, which included around 70% of our patients, were steroid responsive, while the rest of our patients were not steroid responsive, for which we gave other therapies like ruxolitinib, ATG, tocilizumab, or etanercept. The cumulative incidence of chronic GVHD was around 25%. Out of those 25%, around 55% of patients were steroid responsive, while for the rest of our patients, we had to go for other therapies. So the major complications which we faced during haploidentical transplantations were hemorrhagic cystitis, followed by gram-negative bacteremia. And in gram-negative bacteremia, the most common organisms which were detected were E. coli MDR and Klebsiella MDR, followed by tuberculous empyema in 3% of our patients, followed by cardiomyopathy in 3% of our patients. So coming to the non-relapse mortality, which was 8% at 1 year, and it was the rate of relapse was 6% at 1 year. Transplant-related mortality, which was defined as the mortality due in first 100 days of transplant due to any cause, it was around 39%. The main causes of death which we studied were primary engraftment failure in 22% of our patients with acute GVHD, with other causes like tuberculosis, followed by sepsis and septic shock, then hemorrhagic cystitis and cytokine releasing syndrome, which occurred in 1 out of 36 of our patients. So the overall survival, median overall survival at 18 months was around 50% in our patient, and same was the progression-free survival at 18 months, which was around 50%. So this is a trajectory of our patients showing the follow-up with status of the patient, the red lines showing the dead patients and the green line showing the alive patients. You can see there's a huge variation in the follow-up. Some had follow-up of only few days, while the rest have follow-up of around 4 to 5 years. So when we compare our results with the previous studies, we see that our results are comparable. This is a study which was published in Journal of Bone Marrow Transplant, and it was done by Luznik, and it was done on the patients of hematological malignancies. It was seen that the overall survival in these patients at 2 years was around 50%, which is comparable to our study. While the relapse rate was much higher than our study, the relapse rate was around 60% at 2 years, and non-relapse mortality was around 15 to 20%, which is much higher than our study. So was the study which was published in Journal of Clinical Research, and it was done by Jaiswal. In this study, the overall and progression-free survival was around 60%, and relapse rate was much higher, which was around 25%, and while in our study, it was around 6%. So coming to the summary slide, we did haplotransplant of 36 patients in total with a median CD34 dose of 6.5 million cells per kg. Median day of neutrophilic engraftment was day 14, followed by platelet engraftment at day 15. The cumulative incidence of acute GVHD was around 30%, while the chronic GVHD rate was around 25%. Relapse rate at 1 year was 6%. Non-relapse mortality was around 8%. TRM, which is a transplant-related mortality, occurred in around 39% of our patients. Overall survival and progression-free survival at 18 months was around 50%. Thank you.
Excellent presentation, and I think in Pakistan, in a resource-constrained environment, to do hepatotransplants and to have that data on is really appreciable. I've got a few things to ask really. So, which procedure you use for desensitization?
Sir, we usually follow John Hopkins protocol and MD Anderson protocol, and in which we do plasmapheresis with 4 to 5 episodes of plasmapheresis. If the patient does not respond to plasmapheresis, or if the donor-specific antibody remains positive, then we can give IVIG followed by rituximab. So basically, we follow the Johns Hopkins protocol or MD Anderson protocol.
And in your case series, like in your study, how many patients required that?
Only one of our patients underwent desensitization because he had MFI, very MFI of more than 3,000. So we did a desensitization protocol in one patient. He was around 10 years of age and he had diagnosis of aplastic anemia. And he responded to that desensitization and he underwent transplant.
Good, excellent. And what was the oldest age group you had? So more than 40 was, you had
45 years of age.
So the oldest was 45.
Yes, 45.
Another thing was that, we are experiencing CMV PCR or CMV reactivation a lot more higher. In your cohort, it was just like, I think, 30%?
Yes, because we give CMV prophylaxis to our patient in the form of ganciclovir. We did another study with CMV reactivation who were to those patients who were given CMV prophylaxis, and we compare to those who were not given. We did another study. So we usually give from ganciclovir prophylaxis to our patient, all of our patients from day -8 to day -1, and then we stop. So due to this ganciclovir prophylaxis, the rate of CMV reactivation is much lower in our setup.
And do you experience any renal impairment or any side effects from ganciclovir?
Yeah, we do face, but it is very lesser. So the main the main complication which we face is usually pancytopenia, so or engraftment failure. So that's why we stopped before transplant or the day before infusion of stem cells.
Okay, I think that's all from my side.
Thank you. But I think, yeah,
Thank you.
Well done.
Next. Adiba Zaki here. Okay, so our next presenter is from Aga Khan University Hospital, Karachi, and it's Adiba Zaki. She is presenting survival outcomes among patients with high-grade glioma, a single institute experience.
Assalamu alaikum, everyone. So I'm Dr. Deepa, consultant oncologist at Aga Khan University Hospital. First of all, I would like to thank Shaukat Khanum for giving me this opportunity to present my study. So today I'll be presenting our data on the survival outcome among the patients with high-grade glioma, a single institution experience. So a little about the introduction. As we all know that the high-grade glioma include all the grade 3, grade 4 primary brain tumor of the astrocytic, oligodendroglial, and mixed cellular lineage as per WHO classification. And these are all associated with poor prognosis. The standard of care, which includes concomitant chemoradiation with temozolomide and followed by the monthly temozolomide, that's shown the median survival of about around 12 to 15 months in glioblastoma and approximately 2 to 5 years with a newly diagnosed anaplastic glioma. Despite of the standard treatment, many of the gliomas do recur. The prognosis is poor with the median survival of about 3 to 9 months at first recurrence, which drops to a few weeks or more than 90% for the patient with second or subsequent recurrence. So management of the recurrent glioma is really complex, mainly include the surgery, re-radiation, and the systemic chemotherapy. So as we know that malignant gliomas are usually highly vascular tumor and it expresses a high vascular endothelial growth factors. So bevacizumab is a humanized monoclonal antibody that binds and inhibits vascular endothelial growth factors, and it has demonstrated the activity, synergetic activity with the combination cytotoxic chemotherapy when used in combination in the treatment of recurrent glioma. There are many therapies have been approved in the treatment of recurrent glioma, but there's no head-to-head comparison that which one is better than other. The favorable results have been reported in some studies showing the durable response rate during the combination of bevacizumab and irinotecan in the patient with recurrent glioma. However, to our knowledge, no study from Pakistan has been conducted yet to determine outcome of the patient with high-grade glioma. So main objective of my study is to determine the overall survival and the progression-free survival after the first and second line of treatment, the patient with high-grade glioma at a tertiary care center in Pakistan. So basically, it is a retrospective analysis. It includes all the patients with the high-grade glioma who presented at Khan University Hospital from 2016 to 2021 who received the standard treatment, that is a concomitant chemoradiation and temozolomide, and on recurrence received bevacizumab with or without irinotecan were included. So this is basically a basic study design that includes all the patients after the surgical resection or the biopsy who received chemoradiation, followed by temozolomide in the adjuvant setting, either for the 6 cycles or the 12th cycle or until the disease progression. On the recurrence, they received irinotecan or bevacizumab. The primary endpoint was a progression-free survival and overall survival. Secondary endpoint included PFS and OS with respect to histological subtypes. So basic characteristic of my studies, the median age was 51. 68% of the patients were male, while 31 were female. Most common site of the primary tumors was frontal, followed by temporal. As per the histological subtypes, the most common reported pathology was glioblastoma, that's about 66% cases, followed by the anaplastic glioma around 25%, and then 5 to 2% anaplastic estro or anaplastic oligoestro. The primary treatment, surgical resection, 64% of the patient have the subtotal resection, while 23% has a gross total resection, and 11% who underwent only biopsies. So the systemic treatment received that the most of the patient received 74% received the CCRT, followed by temozolomide until disease progression, while the 16% received the adjuvant temozolomide for about 6 months and 8% received about for 12 months adjuvant temozolomide. So taking the consideration, the molecular markers, IDH mutation was reported in about like 8% of the patient, while it has not been done in majority of the patient. Similar that 1p19q was reported to be positive in about 11% of the patient. 97 patients progresses and they received the second line chemotherapy. The combination was given irinotecan bevacizumab in 64% of the patient, while single agent irinotecan was given in about 18%. So these are the results. The progression-free survival after the primary treatment median was 18 months, and the PFS after the second line treatment was about 14 months. The overall survival in the entire patient glioma was median about 37 months. So this is chart just showing the overall survival benefit. On looking the subgroup analysis as per the histological subtypes, the median PFS was found in the patient with GBM after the first and second recurrence was 16.5 versus 14.5 months respectively, with the median overall survival about 36 months. In the patient with anaplastic oligodendroglioma, the median PFS was around 22 versus 13 months, whereas the overall survival was about 37.5 months. And a plastic astrocytoma, similar, the result was reported about after the first line was PFS was about 9.5 versus 19 months in the second, after the second line, and overall survival was about 43 months. So despite of the multiple therapies have been developed, relapse of the high-grade glioma is inevitable for almost all the patients. The management of the recurrence in the glioma is still challenging. The resistance to the treatment of the tumor cell, the heterogeneity, and the evolution of the subclonal population, cancer cell continue the tumor, as well as genetic features of the tumor seems to be the pillar of the progression and failure of the therapy. Drug mostly used in the recurrent setting are alkylating agent or anti-angiogenic agents alone or in combination with other molecules. Studies have shown that superiority of most of the bevacizumab-based therapy compared to the other therapy in the term of PFS. However, this effect does not translate into overall survival. The median overall survival for the bevacizumab monotherapy was reported around range from 3.4 months versus 12.6 months. In the combination, when it's used, the median survival had improved a little bit from 6.4 months to 11.0 months with the bevacizumab and the combination. For the bevacizumab monotherapy, the median PFS is ranged from 1.8 to 5.3 months. Similarly, when it's used in the combination, the survival benefit is like ranges from about 2.3 months when used with about bevacizumab with carmazine to 5.6 months when used with the combination with irinotecan. So our data reveal that combination of bevacizumab, irinotecan improve the outcome in the patient with high-grade glioma when compared to the historical results. Survival rates were higher as reported in international studies and should be considered as standard of care in the recurrent high-grade glioma. So thank you.
This patient had surgery in Alahan.
Yeah, this is all the AHAN data, yeah.
And you mentioned that some patients received 6 cycles of temozolomide and some received 12 months.
Yeah.
So what was the difference?
So patient who have the GBM who underwent the gross total resection, as per STOOP trial, they received the adjuvant treatment of temozolomide for the 6 months. And the patient who had the oligoanaplastic oligo, they received, who had gross total resection, they received for the 12 month of adjuvant temozolomide. These both patients who had the gross total resection, these were the categories.
And you follow them how often after the completion of treatment?
So every 3 months with the repeat MRI and earlier MRI if the patient is symptomatic.
Again, very good presentation. Please.
What is your protocol for re-irradiation of the recurrent GBM?
So protocol. So
Any protocol for re-irradiation?
So basically, the radiation oncologist would, we discussed our patients' tumor borne, that radiation oncologist was better help to tell us about the re-radiation is possible or not.
Because now,
Yeah.
this is just entering
Mhm.
the information I will have like neurosurgeon. So our protocol is once patient get all treatments, surgery, biopsy, and then after that, chemotherapy, radiation therapy. And if there is still a recurrence after some time, we can give radiosurgery as a salvage treatment. You know, and at least you can improve the quality of
Yeah.
the patient for few months.
So it all depends upon the recurrence, right? The site of recurrence, if it's treated in the previous recurrence, the previous treated field or not. So it all depends upon the where the recurrence is, extent of the relapse-free survival and what the radiation.
So normally if a patient has received 60 gray, what dose do you give again?
No, because our treatment is localized. We don't touch the normal brain tissue in radiosurgery, right? So 10 to 20%, depending on the location of the tumor. 10 to 20% less dose here. The single dose, or it depends on the size of the tumor. Now with the new machine, we are giving 3 to 5 fraction, maximum 5. So our dose for this is 20 gray prescription dose with 50%.
So the role of stereotactic radiotherapy or cyberknife, as we say, is quite controversial in GBM. It's not the standard of care yet.
Yeah,
Even in recurrent disease, it's not, because basically the biology of these are primarily mixed brain tumors and they have a diffuse nature. So it's very difficult to define their margins or treat with them. But yes, if the patients do have a good disease-free interval and
Yeah.
the recurrence is very localized, then these can be exceptional cases, but it's not a routine standard.
Yeah.
Yeah, usually GBM, they are infiltrating.
Yeah.
Yeah.
So, but if there is no other option, you can't say the patient, okay, go and wait for your death, right? So as a salvage, we can give, and there are a lot of paper.
Gigi, thank you for the, so Dr. Deepa, thanks a lot for the excellent
Thanks.
presentation as well. So well done. We'll move on to our next speaker. So our next speaker is Dr. Samin bin Naeem. He's going to be talking about clinical pathological features and outcomes of ovarian granulosa cell tumor. He's from Shaukat Khanum Hospital.
लोड करवाई थी
हाँ
अभी है आपके पास
I think what Dr. Munir creation the audience.
कौन सी
Assalamu alaikum. I'm Dr. Samin. I'm doing my fellowship in medical oncology from Shaukat Khanum Hospital, and I'm going to present my abstract about the clinical pathological features and outcomes of granulosa cell tumor of the ovary. So I have no conflict of interest. Ovarian cancers are the most common gynecological malignancies which results in death, and granulosa cell tumors of the ovary accounts only for 2 to 5% of the ovarian cancers. And these are of two types. Adult type comprises of 95%, while juvenile type comprises of 5% of the patients. And the peak age for adult type is 50 to 55 years, while for juvenile type, it occurs in women less than 30 years. So it commonly presents with signs and symptoms of excess estrogens. These are diagnosed at an early stage and have an indolent clinical course and had propensity for late relapses. And more than 90% of adult granulosa cell tumors are confined to the ovary. And 10-year survival for stage 1 is 80 to 95%, for stage 2 it's 50 to 65%, for stage 3 to 4 it's 17 to 33%. And even if it recurs, the mean survival is about more than 5 years. Broadly speaking, for management of early stage, it's surgery. And for advanced stage and high risk stage 1 patients, we usually prefer adjuvant chemotherapy as well. So high risk features are large size of more than 10 centimeter, stage 1C, poorly differentiated, high mitotic index, and tumor rupture. Most common chemotherapy use is platinum based. So the aim of this study was to evaluate the clinical pathological features and outcomes of granulosa cell tumor treated at Shaukat Khanum Hospital. And it is by far the largest data we have gathered over the time of from January 1995 till December 2017. Prognostic parameters for relapse and survivals were seen, and calculations for disease-free survival and overall survival were done. The mean age was around 40 years with a range of 13 to 77 years, and duration of symptoms were of 7.2 mean with duration with the range of 1 to 22 months. Most patients had ECOG 0. They were premenopausal, multiparous, abdominal pain and dysfunction uterine bleeding were the most common presenting complaints with a duration of 3 to 6 months. Right-sided adnexal masses were common finding in the pre-op imaging. Most of the patients had completion surgery in around 48%. Left-sided tumors were common post-operatively. Most had intact capsule with no SRTs, no peritoneal spread, no mental involvement, and tumor size were less than 10 centimeter, 27 patients, and more than 10 centimeter in 27 patients. Most had no residual disease post-operatively. So stage 1 patients were around 85%, stage 2 1.9%, stage 3 11%, stage 4 1.9%. Adult type were documented in 85% of juvenile type and 14.8%. Around 38% patients were given chemotherapy. Broadly, platinum-based chemos were given. So for disease-free survival, the median disease-free survival was documented 60 months with the better outcomes for earlier stage, as we can see the blue line here. It's for stage 1, which comprises 89 months. For stage 2, it's 56 months. For stage 3, it's 42 months. And for stage 4, it's around 8 months. So out of 54 patients, 11 patients relapsed. And the abdominal pain was the most common presenting symptom, followed by abdominal distension. And 1 patient was asymptomatic. Around these 11 patients, 6 patients had residual disease in their postoperative scans, and the initial stage for relapsed patients was stage 1A in 5 patients, stage 3C in 5, and stage 4B in 1 patient. Abdominal mass was the most common imaging finding at relapse, followed by extensive peritoneal disease and left adnexal mass. 6 patients were offered surgery, 4 debulking surgery, and 2 patients had completion surgery. And chemo was given to 73% of the patients. 1 patient refused further treatment, and 2 patients were not fit for any sort of treatment. 3 patients went into remission, and 2 patients still had active disease, and 6 patients unfortunately died. 4 patients had advanced disease at presentation with median overall survival of 58.5 months, around 5 years. And the remaining 2 died patients had stage 1A. Both had 3 relapses before death, with the median overall survival of around 7 years. So this is the graph Kaplan-Meier chart showing overall survival with the median overall survival of 62 months. Stage 1 had 95 months, stage 2 56 months, stage 3 106 months, and stage 4 179 months. Since we had only 1 patient with stage 4B and she is still alive, so the overall survival is 179 months in stage 4. For the relapsed patients, patients presented at early stage and completion surgery with no residual disease had better survival and disease-free outcomes, as we can see with the p-value. And the postmenopausal patients who had more advanced disease at presentation with capsule rupture, presence of SRTs, mental involvement, peritoneal spread, and residual disease after surgical resection were the main contributing factors towards the outcomes affecting progression-free survival. So we had 2 outstanding patients, which were first patient was diagnosed in is 2002 actually for stage 1. She had first relapse in 2008, second in 2010, third in 2013, fourth in 2020. And afterwards, she was under active surveillance with tumor markers. We found out that her alpha fetoprotein started rising. So we did her workup. She was diagnosed as a new primary with a very early stage hepatocellular carcinoma. She underwent RFA, radiofrequency ablation with curative intent. And she is currently on follow-up with imaging suggesting stable disease with overall survival exceeding 22 years, mashallah. And the second patient was diagnosed in 2004. She had stage 1A at that time. First relapse was in 2007, second 2008, third in 2013, fourth in 2016, fifth in 2019, and sixth in 2021. She is currently taking hormonal therapy with overall survival exceeding 18 years. So in conclusion, patients with granular cell tumor presented in early stage and combination surgery with no residual disease more readily achieved with better survival and disease-free outcomes. And postmenopausal patients, more advanced disease presentation, capsule rupture, presence of ascites, mental involvement, peritoneal spread, and residual disease after surgical resection were the main contributing factors towards poorer outcome affecting progression-free survival. And patients with recurrent granular cell tumor showed better survival outcomes if optimal debulking is achieved with or without adjuvant chemo. And resection of metastatic deposits also contributed towards better survival outcomes. And hormone therapy is also being tried for effective granular cell tumor with better survival outcomes, and it has better outcomes in our survival as well. Thank you. Questions?
So next presentation of Sumi. What two questions there is okay. So basically what happens is that you are involved in you mentioned that in a debulking, in a recurrent stage, if debulking is possible, that should be done. That needs a close collaboration between all the team members, including the surgical team as well. So what was your experience in this study in the context of when you have reviewed all the patients' details and notes in the context of surgery plans, and was it being done timely and so on?
Because of their indolent course and propensity for late relapses, the only treatment options were the metastatic, the resection of metastatic site. One patient had first relapse in the right upper lung lesion, and that was resected at that time, and she never had any lung relapse afterwards. So we also, she also had chemo afterwards, and even one patient had 3 to 4 surgeries in her 22 years of 22 years course of treatment. She is fit and healthy and with a current ECOG of 0 at this stage.
She's doing well.
Yes.
Okay. So, thank you.
Thank you.
Thank you.
So our next presenter is Dr. Aftab Ahmed Khan from Kuwait, Gamma Knife Center in the Sina Hospital, Kuwait. He is going to talk about stereotactic radiosurgery for brain metastasis from breast cancer.
Thank you very much. I'm Dr. Aftab Khan. I'm a neurosurgeon actually, but subspecialized in radiosurgery from University of Pittsburgh. And I have an experience of 15 years in radiosurgery. So I want to tell a little about radiosurgery. So what is gamma knife radiosurgery? So any radiosurgery, either gamma knife or linac based, they all are the radiosurgery. So we call it stereotactic radiosurgery. This is a novel technology and a tool in neurosurgery, which is used to treat patients with different neurosurgical disorders. So machine which we are using now in Kuwait, even in Karachi, it is called as an icon, and it produces 192 gamma rays to destroy tumor or making a lesion in a single session. So tumor must be smaller than 3 centimeters, and side effects in this are very rare. I will explain afterward the side effects. So here I already explained that there are 3 types of ionizing radiation used worldwide in radiosurgery. That is gamma rays, which are produced from the cobalt-60, then X-rays, linac-based, CyberKnife, Zapex. Zapex is a new machine which is still in few centers in USA. It is working, and proton beams. So in Pakistan, we have 3 gamma knife units. All are in Sindh, 2 in Karachi, and 1 in Gambit. and 2 CyberDrive machines. One in Karachi, second, I think, in Gurki Hospital. I don't know, it's working or not. It's working already. Okay, so these are our indications for stereotactic radiosurgery. Most commonly, we treat metastatic lesions. Then benign lesions like meningiomas, acoustic neuromas, pituitary adenomas, malignant chondrosarcoma, or the high-grade glial or glomus tumors, we treat only when there is no other option. And vascular malformation we treat, cavernomas we treat, then the functional disorders like trigeminal neuralgia, like movement disorder, only the tremors we treat, doing gamma thalabotomy. So now I'm going to tell you about the brain metastasis from breast carcinoma. It is estimated that 20 to 40% patients with their extracranial primary cancers, lung carcinoma, colorectal, breast, renal cell, they will develop brain metastasis during the course of their illness. So incidence of brain metastasis from breast cancer constitute the second most common cause among all brain metastases, and it ranges from 14 to 16. But in my study, the first cause of brain mets is breast carcinoma. So patients with HR negative and HER2 positive metastatic breast cancer are the most likely to develop brain metastasis. Radiosurgery is an alternative, or we can say can be an alternative to surgical resection or whole brain radiation therapy for a single or multiple metastasis. Radiosurgery is a type of radiation therapy. It is now established as a subspecialty in neurosurgery. It is in US, and it is established as a tool in radiation therapy in US. That delivers high dose of radiation in a single fraction or multiple fractions, sparing the surrounding normal tissue. So stereotactic radiosurgery plays a dominant role in the management of patients with 1 to 10 brain metastasis. So before we were thinking that we were just dose planning was based on the lesions which were smaller than 3 centimeters in diameter. But now the studies have come that if the patient has multiple lesions, brain metastasis, and the total cumulative volume is less than 25 cubic centimeter, we can treat with gamma knife radiosurgery, either in a single fraction or multiple fractions. So what are our guidelines? How do we select the patient for gamma knife? So it is actually a teamwork. Neurosurgeon, radiation oncologist, and a medical physicist. So which patient should have craniotomy? If you don't know the cause of lesion, I mean for histopathology, and the second is large volume tumor, the tumors which are causing mass effect. The patient come to you with the raised intracranial pressure, then you have to go for surgery. And second is which patient should be considered for whole brain radiation therapy or the other tools which radiation therapy is using, with the patients with carcinomatous meningitis and with Mallory disease. And which patient should have a radiosurgery? Solitary with less than 3 centimeter diameter, multiple from 2 to 10, even more if the volume is less than 25 cubic centimeter. So this is these are our guidelines by the International Radiosurgery Association, the patient which I already explained. So this is our experience at Quith Gamma Knife Center. I have treated about 216 patients with 783 brain metastasis. Breast carcinoma patients were 122 with 504 tumors. All patients were selected for stereotactic radiosurgery in a multidisciplinary team. all patients were referred from neurosurgery department and the Kuwait Cancer Control Center. And two different models we used for radiosurgery. That was this was the old one. Now the latest is ICON. So these are our patients' characteristics. Median age 49.7. The minimal age was 30, and the maximum was 76. All the patients have Karnofsky score above 70, and the primary disease was controlled in 70 patients and uncontrolled in 52 patients. Single brain met was discovered in 45 patients, while the multiple in 77 patients. 28 patients came after the surgery and 18 patients came after the whole brain radiation therapy. So this was the molecular pathology of the patients and what were the radiosurgical parameters, tumor number. So these were the patients. One tumor was one or solitary. It was found in 45 patients and the others had multiple. So the maximum tumor which I treated was 17. But these patients, they did not come with the 17 brain mets. They came first time 5 or 6 metastases, and after 3 months, there were new small. So I have calculated total. So the mean tumor volume was 8.941. So the minimum was 0.131 and the maximum was 26.185 cc. Prescription dose, the minimum was 15 and the maximum was 25 gray. And the mean ISO dose line was 55. And the total procedures I have performed 169. Single fraction was given in 134 patients and the multiple only 2 to 3 fractions. More than 3 I have not given. It was given in 35 patients. So this is our planning system. We are using Glaxal frame 4G, but now we have the Vantage, this second one. This is the new frame we are using, but most of the patient we are using mask for the immobilization of the head. So this is our after that we are taking patient for MR. So this is our protocol. And the dose prescription is according to the size of the tumor. So 2 cc to 4.2 cc 20 gray, 4.2 to 13, 15 to 16 gray with 50% isodose line, and above 14, 13.5 to 14. So these are my patients. This is the patient, 70 years old, female Kuwaiti patients. Her KPS Karnofsky score was 100, and the primary disease was for the last 25 years, breast carcinoma and brain metastasis in 2020. So she came first time with 5 metastases and the second time with 7 metastases. Now total follow-up is 16 months. Clinically, she is asymptomatic. MRI disappearance of all metastases after 3 months. Complication, no. So you can see above is before gamma knife, and after 3 months after gamma knife, you can see all the tumors disappear. This is a 3-month period. This is a second case, 47 years old, female, primary disease, CA breast since 2018, and after 1 year, she has brain metastasis. So her Karnofsky score was 70, and above is, above you can see the 2 lesions. One is in the left cerebellum and the second is in the left frontal. And after 3 months post gamma knife, you can see a very small part is left. But patient expired after 4 months due to her primary disease because it was not controlled. It was very aggressive. This is another case, 58 years old lady with breast carcinoma. Patient is asymptomatic. Also within 3 months, it disappeared because the follow-up MRI after doing gamma knife is 6 weeks and 3 months. So within 3 months, the tumor disappeared in the left occipital region. This is another 57 years old female Kuwaiti, primary disease, breast carcinoma, 9 years. After 9 years, she has a brain metastasis. So clinically, she presented with headache, neurologically alert oriented, Karnofsky 100. So gamma knife was done. So the volume of the tumor was 3.9 cc. 20 gray I have given with 50% isodose line. Within 6 months, the tumor disappeared in the right temporal region. So these are the results. Total of 122 patients with 504 brain metastasis. Median follow-up time was 5.9 months. Median overall survival 15 months, and the median intracranial progression-free survival 7 months. Median tumor control rate above 90%. So in my study, I have found the factors related with long survival are young age, good Karnofsky score, primary disease control, and location of the tumors. So complication in about, you can say 10% patients I have found complications. Complications were almost 2 types. 8 patients had ARE, adverse radiation effect, edema, and the 4 patients, they had radiation necrosis. So this was one patient. After 3 months, tumor disappeared, but after 24 months, post gamma knife, again tumor appeared. We did PET scan, and it was radiation necrosis, and we managed her surgically because it was causing the mass effect. So conclusion, stereotactic radiosurgery seems to be a feasible and safe treatment for single or multiple brain metastasis from breast cancer in selected cases, and is associated with low complication rate. Radiosurgery achieves a very good local control of either newly diagnosed or recurrent brain metastasis from breast cancer. A multidisciplinary approach is also important to integrate surgery, stereotactic radiosurgery, whole brain radiation therapy, chemotherapy, and targeting therapy in a hope to preserve at best neurocognitive function and quality of life. Thank you very much. So this machine we have, this is icon. This is the latest machine. Now the new model also arrived, but it is only in the Sweden at the moment. That is more robotic. And beauty of this machine is that it is actually in USA also, it is linked with neurosurgery. So neurosurgery department, and they use like a tool in neurosurgery. Okay. But I will say that still the gold standard for neurosurgical disorder is surgery. We only use this machine in brain mets as a primary mode of treatment, or recurrent, or the residual tumors of the brain. Otherwise, these are our very strict guidelines. Okay.
So most of the patients that you are receiving are from brain cancer control?
Yes, most of the patients.
Most of the cancer patients are followed there.
Yes.
Then once you treat the patient, they are referred back to them for follow-up, or you follow them yourself?
I follow them.
You follow them.
Because they are coming to my OPD.
Okay.
Yes.
Any questions from the audience?
I'm Dr. from Karachi, and I work at Gamma Center Technology. So I have a question that what are the organs that this that you are concerned about to contribute to brain mets?
In mets, depending upon the location of the lesion, right? But anyway, if the tumor is very close to the eloquent areas, like optic apparatus, okay. Amygdala, you mean in the temple region, or because we only, gamma knife is very precise, very, very precise. But if the tumor is there, you can't do anything, right? As compared to the whole brain radiation therapy, right? So eloquent area, we are not touching, because now in this machine, we can block also from that side,
Thank you very much. Very nice presentation.
My play.
The next presentation is from, it was from Dr. Wajia, but she is not here. So Dr. Akil are you? And हाँ अकील अकील आपका टॉपिक क्या है इसमें वही वाला है ओके so the topic of Dr. Wajia was hospital based study of endometrial carcinoma 5-year survival of patients treated with adjuvant radiation.
Assalamu alaikum everyone. I am Dr. Keel Shahid and I will be presenting a hospital-based study of endometrial carcinoma, 5-year survival of patients treated with adjuvant radiation. So endometrial cancer is the most common gynecological malignancy in high and middle income countries. Over 4,000 cases were reported worldwide in 2020 alone. And North America and Europe have the highest incidence of endometrial cancer owing to their high income states. So we can see on the map that usually the countries with the higher income rates have more prevalence of this disease. Coming to the Pakistan statistics, 2,881 cases were reported in 2018 as per the Globocan data, with a overall mortality rate of only 0.96%. So these patients tend to do better than most of the other cancers. But although the overall prognosis is relatively good, the mortality caused by endometrial cancers have been found to be highest among the women who with low socioeconomic status, and possibly because there is a lack of evidence-based care in these settings. As we know, in most of the low economic settings, the practice-based or the evidence-based practice is not being followed. So that results in a higher mortality rate of these patients. In Pakistan, there has only been a single retrospective study which has compared the overall survival of type 1 and type 2 endometrial cancers. And this is the only data which is available in our country. So with that, we come to our study, which is to assess the overall survival of patients with endometrial cancers. And this is stratified by stage and adjuvant therapy after surgery. The study was a retrospective descriptive analysis. It was conducted in Shaukat Memorial Cancer Hospital. Total number of patients were 122, and the time duration of the patients that were taken were between 2016 to 2017. All non-metastatic endometrial cancer patients who were treated with radical intent were taken, while metastatic patients were excluded from the study. And the overall 5-year survival was estimated using Kaplan-Meier curves in SFCS version 28. So there will be a lot of curves going forward. The basic characteristic was the age. The mean age was 60.2, with patients ranging from 33 to as 85. The average BMI, the mean BMI was 30, with ranging from 28 to 40. Most of our patients were FIGO stage 1 and 2. While also a few of them were reported being FIGO stage 3 and 4. Endometrioid adenocarcinoma was the predominant histology, and 59 patients, or 48.4% of the patients, were only treated with surgery, while 63% of the patients were offered adjuvant therapy after surgery. Sorry, we have a slide missing. I don't know how. So this is the overall survival. You can see that the overall survival of our patients treated between 2016 and 2017 was a whooping 98.4%. So this is quite comparable to the international data that has been posted. And this is a combined overall survival of patients who were treated either with surgery or with surgery and adjuvant radiation therapy. If we further stratify the data on the basis of the stage 1 and 2 patients, the 5-year survival was 100%. Actually, no patients who were given either surgery or treated with surgery and adjuvant therapy actually had survived for the whole 5 years, while this data for stage 3 and stage 4 was much lower. And we have another missing slide. I don't know. So if we compare the data of surgery versus surgery and adjuvant therapy, surgery and adjuvant therapy is a comparable data with around 99% of the patients surviving who were treated with adjuvant therapy following surgery. So in endometrial cancers, there is a criteria which is followed for adjuvant therapy. It depends upon the size, the grade of the tumor, and the LV on the pathology. And according to that, the adjuvant therapy is decided. So the adjuvant therapy over here is accounted for all the patients who had received either chemotherapy, brachytherapy, or EBRT, or all three trimodalities. While the patients who were treated with surgery alone had lesser overall survival as compared to those who received adjuvant therapy. So if we compare our data to the international one, this is the CS data, which was published back in 2020. So patients with localized endometrial adenocarcinomas, the 5-year relative survival rate is 96%. So this is quite comparable to our data. Coming to the initial point which was raised, the point was actually raised by WHO that the mortality rate of endometrial cancers is quite high in low socioeconomic status. So considering our society also belongs to one of them, our data is comparable to the international standards because the treatment offered over here is quite standardized. The surgery is quite standardized. The radiation, the brachytherapy, and the chemotherapy is all according to the international guidelines which are being practicing globally. If the patients who had regional lymph node metastases had a 5-year survival of 71%, and while distant did not do much well. So to conclude, patients with non-metastatic endometrial carcinoma treated with single or bimodality treatment have an excellent outcomes in terms of 5-year survival. And our data is quite comparable with the rest of the world, but further prospective trials are needed in this regard to actually show up. Thank you very much. Any questions?
Have you faced any case of brain metastasis from the uterus?
No, sir. Not really.
I have done this.
Brain mets is very rare in endometrial cancer.
In follow-up, what do you do, Dr. Gill, in this patient? What diagnostic procedures do you do?
So the usual follow-up is with the MRI, CT, chest, abdomen, pelvis. And the CT chest, during the first 2 years, it's just been done after every 6 months and yearly after that.
Yeah. Thank you. Any other questions? Thank you, Dr. Keel. So our next speaker is Dr. Yasir Inam. Have you got Dr. Yasir now? Yes. So he's going to talk about priority treatment in patients with esophageal squamous cell carcinoma, an experience of a large cancer center in Pakistan. This is Dr. Khanum.
Yeah,
Assalamu alaikum, everyone. I'm Dr. Yasir Inam from Department of Clinical and Radiation Oncology, Shaukat, Khanum, Peshawar. And I'm going to talk about my research, trimodality treatment in patient with esophageal squamous cell carcinoma, experience of a large cancer center in Pakistan. So there is no conflict of interest. Sorry. Is it okay now? Okay, thank you. There is no conflict of interest. And the learning objective of my study is to understand the role of neoadjuvant chemoradiation in managing patient with esophageal squamous cell carcinoma, and to evaluate the proportion of patient achieving pathological complete response after neoadjuvant chemoradiotherapy. So as we can see in this graphical representation that worldwide there is increasing incidence of esophageal carcinoma in women as compared to men. In Pakistan, it is 7th most common cancer in men and 6th in women. So as far as the staging is concerned, so those tumors who are limited to the mucosa of the esophagus are staged T1A, and those tumors who involve adjacent structures are staged as T4B. As far as prognosis, So overall prognosis is 54.5%, and for stage 3 cancer, the overall prognosis is 38.3%. For stage 4A, it's 23.6%, whereas for stage 4B, it's 18.2%. So the general treatment paradigm for esophageal cancer is for stage 1 is surgery, stage 2 and 3, it's neoadjuvant chemoradiation followed by surgery. And for few selective cases, definite chemoradiation can also be considered. While in metastatic setting, the mainstay of treatment is systemic therapy as well as palliative radiotherapy. So the objective of my study is to determine a pathological complete response rate in patient with squamous cell carcinoma post-neoadjuvant chemoradiotherapy. So it was a retrospective review of 218 patients treated in our hospital with the neoadjuvant chemoradiation followed by surgery from January 2018 to January 2021. So these patients were treated with the neoadjuvant chemoradiation with a dose of 45 to 50 gray and 25 friction, 5 friction in a week from Monday to Friday, with concurrent chemotherapy, weekly chemotherapy. And a response assessment scan was done at the 6th week, and those patients who showed good or partial response were referred to surgical services, and they underwent minimal invasive esophagectomy or transhiatal esophagectomy. So the main characteristic of the patient, the median age was 45 years, and the male population was 47.2%, while female population was 52.8%. And all of these patients were stage 2 and 3, and 72.1% were node positive, while 27.9% were node negative. And all of them were squamous cell carcinoma esophagus. So as far as the radiation doses are concerned, 47.2% of the patient received 45 gray and 25 friction, while 52.8% of the patient received 50 gray and 25 friction. And concurrent chemotherapy, 88.1% patient received carbopec chemotherapy, weekly chemotherapy, while 11.9% of the patient received CISCAP chemotherapy. So now coming to the results, so our study showed complete pathological response rate of 64.2% in all the patients. Further breaking down the results, male population, 57.3% of the male population showed complete pathological response rate, while 70.4% of the female population showed complete pathological response rate. And as far as the radiation doses are concerned, so 67.8% of the patient who received 50 gray and 25 friction showed complete pathological response, while those patients who received 45 gray and 25 friction, the complete pathological response rate was 60.2%. So the conclusion of our study is neoadjuvant CRT in patient with squamous cell carcinoma of the esophagus offers a high PCR rates. And further studies are required to evaluate the role of organ preservation in this group of patients with bimodality treatment. Thank you.
Complete pathological responses is good with neoadjuvant chemoradiation, but at the same time, it's related to the dose as well of radiation.
Yes, sir. Because some of the patients received 50 gray and other received 45
You said that
gray.
who received 50 gray had or more pathological responses.
Yes, so it was 67.8% in those patients who received 50 gray and 25 friction as compared to 45 gray and 25 friction.
Yes, so how do you decide between 45 gray or 50 gray? Because the standard dose prime
Yes.
modality is 41.2 gray in composite.
So mainly, madam, those patients, mainly the factor are the tumor location, length of the tumor, and organ to doses to the organ at risk were the main factor in deciding between 45 gray and 50 gray. So those patients who were having low esophageal tumor and with increased length of the tumor were given 45 gray, while other patients were given 50 gray. Thank you so much.
So I've got one more question.
Yes.
So some of your patients had cisplatin-based chemotherapy. They're the ones that got carboplatin-based chemotherapy.
Yeah.
Why was that?
So actually the carbopec concurrent settings is established practice, but we know that from the previous data that squamous cell carcinoma are more sensitive to cisplatin based chemotherapies. So those patients who were very fit and having good performance status were given cisplatin and
So does it have a better outcome?
yes, no, there was no better outcome with concurrent setting chemotherapy.
almost
Yes,
similar
it was similar. Yes.
And any difference in toxicities?
Actually, I haven't reviewed the toxicities in this study, so I'm unable to comment on the toxicities related to chemotherapy.
Any other questions?
Yes.
So one group of the patients received lower radiation dose.
Yes.
And they had lower PCR. So ethically speaking, how would you justify lower dose?
So actually, it's not a lower dose. We can say it's already established dose, 45 gray and 25 friction. Yes.
If I can answer it.
Yes, please, ma'am. Sure.
Yeah, okay.
So actually 45 gray and 25 friction is not a lower dose. It's already established dose from the previous data available. So ethically, we cannot say that we give lower dose to some of the patients and we give higher doses to other patients. So it's equally, and the biological effect of the both doses are the same as well.
Did you had more complication in 50 gray or 45 gray?
There was no such complication reported in both groups to radiotherapy.
So as Yasir already mentioned, that the radiotherapy dose is basically decided on the dose to OARs. We have to balance that your tumor control and normal tissue toxicity as well.
Yes.
You cannot always justify giving a very high dose by giving a very high dose to the normal structures as well and ending up with lot of toxicity. So that is why there is always a range in radiation oncology. There is no one concrete dose for every patient.
Any more questions?
Any other questions?
Thank you so much. Thanks.
Thank you. An excellent presentation. Gee. So we got our next speaker is Dr. Mariam Inayat. So she's going to talk about comparison of dosimetric parameters between whole pelvis versus prostate only volumetric modulation of therapy. Gee.
Assalamu alaikum and good afternoon. My name is Dr. Mariam Inayat and I'm third year resident from the radiation department. I am going to discuss the comparison of the dosimetric parameters and acute toxicity between whole pelvis versus prostate only volumetric modulated arc therapy. So as we know that prostate cancer is the second most frequent cancer in the men and the fifth leading cause of death in the men. Highest incidence is reported in the age of more than 65. The global incidence is reported as in 2018, which is 2.6%, which constitute about 4,552 patients. So external beam radiotherapy is one of the curative modalities for the prostate cancer, which can be with or without hormonal therapy according to the risk group. So when we talk about the external beam radiotherapy, as we know that external beam is well established for the prostate cancer, but during radiation we have to see that our dose is more targeted to the prostate, and our ORRs should be well preserved. So while moving towards the prostate cancer, we have also also see that we have to treat prostate or whole pelvis in case. So in which cases we treat whole pelvis and in which cases we treat prostate only. The patients who are at the high risk of nodes involvement like T3 or more with Gleason score more than 8 and PSA more than 20. These are all the patients have the 15% risk of the prostate cancer, and also those patients who are node positive, they also have the risk. These also treated with the whole pelvis. Yes. Thank you. So how can we minimize the dose to the OARs while treating whole pelvis? So previously, 2D technique was used, which was 4-field box technique, in which everything coming in the way of radiation field was treated, and there was more toxicity to the organs at risk, which are rectum, bladder, and the femoral lengths. With the more advancement, 3D and IMRT came into the way of radiation, and IMRT is the now standard approach for the better dose conformity, more homogeneity, and less toxicity to the OARs. The new and fancy technique of IMRT is the VMAT, which allows the better dose conformity in less delivery time and the low toxicity to the OARs. So in this picture, we can see that the prostate, the target volume is well contoured, and the doses to the OARs is So the objective of our study is to evaluate the dosimetric quality and acute toxicity between whole pelvis versus prostate only. So we retrospectively randomized 125 patients from July 2018 to December 2020. These all were biopsy-proven prostatic adenocarcinoma with no metastatic disease and with of good performance status. CD planning was done according to the departmental protocol, and organs at risk and the targeted volume were contoured. And the VMAT plan was performed for dosimetric analysis. After that, during the radiation, weekly follow-up was done from which the toxicity was graded according to the CTCAE criteria, and the same way 6 weeks and 3 months post-radiotherapy. Most of the patients were localized prostate cancer with T1 to T3 disease, either positive or negative nodes, with or without radiation hormonal therapy according to the risk group. Prostate only patients were 92, and the whole pelvis was treated in 68% of the 68 patients. So this is our dosimetric chart. As we can see that parameters were mildly increased in the whole pelvis group. Volume receiving the 30 gray in the whole pelvis group was 66% as compared to the 58, while in the same way V30 of the bladder was 68 as compared to the 47 in the prostate only group. Similarly, toxicity of the whole pelvis was acute grade 2 rectal toxicity were increased in the whole pelvis group, but there was no significant difference in the terms of acute GU toxicity in the prostate only and the whole pelvis group. So volumetric modulated arc therapy is a new approach, and the whole pelvis, if we talk about treating the whole pelvis in the high risk group, but this is still controversial, and there is ongoing debate in this is because there is no clear data, either it increase overall survival of the patients or not. Considering the delivery efficacy as well as acceptable plan quality of the VMAT, it may be the preferred modality for treating the high risk prostate cancer in the context of whole pelvis. So we conclude that parameters in the whole pelvis do not change the toxicity profile despite large rectum and the bladder volumes in the whole pelvis when compared with VMAT. Further follow-up is needed to assess the late toxicity. Thank you.
Was any randomization or just an observation on the patients who had volumetric therapy or patient had both therapy?
So it is a retrospective trial. So we compared the groups. Like we have chosen the patients who were all treated with the VMAT.
The patients in the very past who had both therapy, the patient in the recent past who had the volumetric type thing, is it a question?
No.
So
These
in your department, how are you choosing the patients if they have both therapy versus that?
So we have chosen the whole pelvis radiotherapy according to the risk group. Like high risk groups and node positive groups are treated with the whole pelvis radiation therapy.
But they do not get any volumetric based.
They do get VMAT. All the plans were according to the VMAT.
Okay.
So in prostate cancer,
Yes.
patients have a high risk group. and they have a high potential incidence of lymphoid metastasis,
Mhm.
occult metastasis, or involved in MRI. The pelvic nodes has to be treated.
Has to.
But in past, with the older techniques, it was very difficult to control the toxicity because of the small hole and the rectum involved, and the dose of radiotherapy and prostate is pretty high. But with volumetric arc therapy, with what we have seen, that even if we have treated the nose based on the risk stratification, these patients tolerated very well, and there was no higher toxicity in that group of patients.
In volumetric.
In
Volumetric.
with
So
this newer technique.
nowadays you are using volumetric for most.
Yes.
of the patients.
Yeah.
Okay. Thank you.
Thank you.
So our next speaker is Dr. Syed Mohsen Raza from Shaukat Khanum. He'll be talking about clinical outcomes of chemoradiotherapy using VMAT for locally advanced esophageal cancer, a single institute experience.
Let's start. Okay. In the name of Almighty, who is the most gracious and the merciful, I am Dr. Mohsen on the Department of Clinical and Radiation Oncology behalf. My topic of my study title is Clinical Outcomes of Chemoradiation using VMAT technique for locally advanced esophageal cancers. So, esophageal cancer is the 8th most common cancer worldwide and 6th leading cause of death. The incidence rate varies globally. In certain parts of the world, the incidence is quite high, like Eastern and Southern Africa and Asia. But in Western world, the incidence is quite low. When talking about Pakistan, the incidence of esophageal in some areas of Pakistan is comparable to that in high incidence region. There are two main histological subtypes, squamous cell carcinoma and the adenocarcinomas. SCC still accounts for majority of cases, but adenos are present in the Western countries. What is the locally advanced esophageal cancer? Basically, T3 disease involving all of the layers of esophagus, transmural extension, or T4 disease involving adjacent organs, or lymph node positive disease that are locally advanced. When talking about the treatment modality, in the treatment of these patients, trimodality treatment has been used. Radiation therapy with concurrent chemotherapy followed by surgery, the best strategy for optimizing long-term survival. Definitive chemoradiotherapy still has a role and is well tolerated in about 1/5 of the population. Talking about radiotherapy, previously 3D conformal technique or box technique was used, and it was the standard of care approach. But as there are more advances in the field of radiotherapy, a more conformal technique like IMRT, which constitutes better dose conformity, homogeneity, and normal tissue sparing. Like I can show you this was previously technique which we were using, the 3D conformal technique. We can see this is our target, but normal structures, both lungs, cord, and heart are in the field of radiation. Moving to the IMRT, the target is well controlled with the radiotherapy dose, and the organs at risk are still minimized. Moving to the technique by which our patients were treated, that was volumetric modulated arc therapy, in which a rotational geometry, beam modulations by the use of MLCs, and high dose variation and gantry rotational angles were used. This is the technique by the gantry rotates around the patient, delivers dose to the target, and stops at the where there are organs which are at risk. Only the dose is delivered to the target. And this, you can see a more conformal plan is achieved. So in comparison to the static IMRT, VMAT allows better dose conformity, lower doses to the OARs, and decreased monitor units and delivery time. This we can achieve via this technique. So objective of my study, to assess the clinical outcomes of locally advanced esophageal cancer treated via VMAT technique with platinum-based chemotherapy. The primary endpoints were acute toxicity via VMAT, pathological CR and extent of downstaging, whereas the secondary outcomes were disease survival and the overall survival. It was a retrospective study done over a period of 3 years, and locally advanced esophageal cancer patients were of good performance status were chosen. And a sample of 121 patients were taken after IRB approval. The treatment schema was esophageal cancer, concurrent chemoradiotherapy with a dose of 50 gray in 25 fractions with weekly chemotherapy regimen, carboplatin with an AUC of 2, and paclitaxel 50 milligram per meter square. After that, after 6 weeks, response assessment scan was done, followed by esophagectomy. Patient characteristics were, majority were of stage 3 and grade 2 patients. And 68 patients were male, whereas the 53 were female. Surgery, which was done, was only in 56 patients. Out of 121 patients, surgery was done in only 56 patients. And the type of surgery, which was the most common, was 3-stage esophagectomy. Complete pathological response was observed in almost 33% of patients out of those 56. The toxicity was, the major toxicity which was observed was esophagitis leading to dysphagia, which was grade 1 and grade 2. The other toxicities, skin reaction and mucositis, constitutes a lesser extent. The overall survival and disease-free survival were almost 22 months and 34 months, respectively. The dose evaluation was done according to this trial, and all of our constraints were matched with this one. Dosimetric analysis, all of the dose constraints are well according to the criteria. In a nutshell, I would just say that trimodality treatment with a standard preoperative radiation and chemotherapy yield good pathological response, long-term disease-free survival at the cost of low acute toxicity. Thank you so very much.
Any questions?
So I'm Arya Tariq, resident of radiation oncology from AKU. I have a question that the patients who did not end up having surgery, what was the reason? Like, was it due to the location of the tumor? Did you end up looking into that?
Yeah, it was also a reason, but majority of the patients were frail and they do not have surgery on that basis. Mostly the tumors were of advanced disease, T4 disease, and after doing response assessment scans, still it was locally advanced and irresectable disease. That's why the surgery wasn't done in those patients.
Before embarking onto any treatment modality, we just saw that all the patients receive 50 and 25. Is that?
Yeah, majority of
irrespective of whether they will be having surgery in future or not.
Yeah, majority of those patients were treated by a 50 grain 6 to 25 fractions.
All right.
Of
So
radiation.
irrespective of whether they'll be having a biomodality or a
yes.
chemotherapy. All right, and we also saw that there were, like you just mentioned, there were some clinically T2s as well. So how did you end up staging them as clinically T2? Do you have a EUS at your center?
Yes, we do have.
Thank you.
All patients get EUS and PET scan as part of the routine staging before deciding on.
Any other questions? Thank you. Again,
Thank
very
you.
good presentation.
Very good presentation.
So our next speaker is Dr. Rija. She's going to be talking about endometrial stromal sarcoma, a 10-year retrospective review.
Fajar.
Sorry.
Fajar.
Fajar. So she's going to be talking about endometrial stromal sarcoma, a 10 years retrospective review of patients treated at a tertiary care hospital in Pakistan.
Assalamu alaikum, everyone. My name is Dr. Fajrafi Ranja, and I'm the Year 4 resident from Clinical and Radiation Oncology, Shaukat Hospital, Lahore. So the topic of my talk today is endometrial stromal sarcoma, a 10 years retrospective review. So we look at the background first. Sarcomas are basically mesenchymal in origin, and they account for less than 1% of all gynecological malignancies, and they carry poor prognosis and are aggressive in nature. Mitotic activity is used as a parameter to classify ESS into low-grade or high-grade tumors. FIGO surgical staging system is used for uterine sarcomas. So generally, if we talk about low-grade sarcomas, the mainstay of treatment is total abdominal hysterectomy and bilateral salpingo-oophorectomy, and for high-grade surgery followed by adjuvant treatment in the form of chemotherapy, radiation, or hormonal therapy. So ideally, hormone receptor status, which is ER/PR, should be done on all pathology specimens. So we'll talk about the objective of my study. The objective is to analyze the clinico-pathological features and outcomes of patients with endometrial stromal sarcoma. The primary endpoint was progression-free survival and overall survival. So we'll talk about the methods. It's a retrospective study. Patients were taken from 2012 to 2021 in the year in 10 years period. Histologically proven primary endometrial stromal cell sarcomas. Age was 51 to 58 years. All stages, FIGO 1 to 4, and performance status of 0 to 2. As it is a very rare cancer, as I've told you before, they account for less than 1% of all gynecological malignancies. So in the span of 10 years, we have only seen 38 such patients. So the treatment scheme was diagnosed case of endometrial stromal cell sarcomas, which underwent surgery and then were offered chemo, radiation, and hormonal treatment according to the low-grade or high-grade status. And then they were followed up. So these are the patient's characteristics. If we talk about age, the median age was 39.5 years, 21 to 58. FIGO, if we talk about FIGO stage, mostly were low, stage 1, which were 60.5%. And then if we talk about histology, most of them were low grade, which is 65%. So we had patients which were stage 1 and low grade, mostly. So if we talk about the treatment, all of them had surgery, as I've told you before. So chemo, radiation, and MIGACE were the adjuvant treatments. 10 number of patients had chemo, 14 had radiation, and MIGACE were offered to 9 patients. So the chemo combination used was taxanes, platinums, and doxorubicin, and radiation dose ranged from 50 to 45 to 50 gray. So these are the results. The progression-free survival at 5 years was 78%, and overall survival was 77%. Low-grade tumors, which were 25 in number, 3 of them had a recurrence. And for high-grade tumors, which were 13 initially, 5 of them had a recurrence during the follow-up period. 27 patients underwent total abdominal hysterectomy and bilateral salpingo-oophorectomy. 11 patients had incomplete surgeries. Some form of adjuvant treatment after surgery was administered to 24 out of 38 patients. And at the median follow-up of 25 months, 6 patients died because of disease progression. So to conclude my study, patients are frequently diagnosed at an early stage, but still experience local or distant recurrence, especially those which have high-grade histology. The prognosis is poor with early recurrence and low long-term survival rates for such patients. Low-grade endometrial stromal sarcoma present at an earlier stage and have a better outcome than high-grade. So there's a lack of prospective trials for ESS due to its rarity. Because of this, majority of current recommendations are for adjuvant treatment. They are based on case reports and retrospective studies. So in order to obtain more information about the pathogenesis of the tumor and to find the optimal therapy, it is necessary that studies, even with small numbers of patients, are undertaken. Thank you.
Questions?
So in your cohort, you said that almost all patients with high-grade what were your criteria for adjuvant?
So for adjuvant treatment, I've told you before, for high-grade tumors, we offer radiation, chemo, or hormonal treatment. So number 1, high-grade histology. Number 2, the patients who had incomplete surgery. Number 3, the margins were positive and node positive disease. These were the things that we looked into when we were offering adjuvant treatment. No, not in all of the patients, but a few of them it was done because they are taken from 2012 to 2021. So some of them had ER/PR. If they were positive, they were offered hormonal treatment in the form of MIGACE.
Any other questions? Ji, please come along.
You said that 5 of the patients developed recurrence. So all these high-grade or low-grade patients?
6 almost had recurrence. 5 were high grade, 1 was low grade.
Ji.
I was asking about the location of the recurrence, whether it was
Both. Mostly high grade were the distant recurrence with local.
Any other questions? So thank you.
Thank you.
Thank you
Dr.
so
Fajr.
much.
Excellent presentation. So we'll move on to our last presentation of the session. This is going to be from Dr. Mohammad Atif Mansha. Initial experience of radiosurgery at Dow University of Health Sciences, Karachi. Ji.
Bismillahirrahmanirrahim and Assalamu alaikum to everyone. I'm Dr. Atif Mansha from Karachi and I work at Gamma Knife Center at Dow University of Health Sciences. So I'll be sharing my experience of reduced surgery at Dow University of Health Sciences. We have been doing reduced surgery for the last 1 year. Basically, it is a form of radiation treatment in which a high dose of radiation is delivered to a small, precisely selected area in few fractions. A Gamma knife is basically a machine which we use at our center. It is a radiosurgical instrument which can deliver a single or multiple fractions, a high dose of precisely focused radiation with pinpoint accuracy to any part of the brain, or it can also include the upper part of the C-spine up till C2 vertebra. This machine consists of 192 cobalt sources, which helps us to confirm the tumor, as well as it has a steep dose gradient, which helps us in sparing the nearby normal tissues. Basically, there are two types of immobilization devices that we use for this machine. One is frame, and the other one is mask. Mask, which most of us know, it is a thermoplastic mask. And with frame, it is a slightly invasive procedure for which local anesthesia is given to the patient. For geometric verification, a cone beam CT is done prior to the treatment. And during treatment, the patient of the position is verified by high definition motion management infrared system, which is mounted on the machine. So all this leads to a precise delivery of the radiation treatment. The objective of my study is to report the demographics, the disease characteristics, and the treatment outcomes of the patients at our center. Basically, it is a retrospective review of our patients, and descriptive stats were performed for socio-demographic information, and proportions were carried out for categorical variables, and central tendencies were carried out for continuous variables. So we started operations on 13th of August 2021, and till 29th December 2022, we treated about 500 patients in 300 days. Most of the patients were male. The mean age of the patients was 43.6 years, and we also had few pediatric patients under the 18 years of age. Majority of the patients were adult patients. When we cross-tabulate the gender and the age, so there is a slight predominance of the male patients in both the age groups, pediatric as well as adult. So this is very interesting data, as all the Gamma knife machines in Pakistan are centered in Sindh. So we see patients from all across the country. Majority of our patients come from Punjab and then KPK. We also see patients across the borders. Most of them came from Iran, Afghanistan, Yemen, UAE, and UK. So this is very interesting for the policymakers, because there is no machine in other regions of the country, and there is a need of this machine, or any machine that can do SRS. The diseases which we treat at our centers are broadly classified into benign tumors, malignant brain tumors, vascular malformations in the brain, functional disorders, and ophthalmological diseases like ocular melanoma and refractory glaucomas as well. So if we stratified diseases at our center, most of the patients had benign diseases followed by malignant brain tumors and vascular malformations. If we further break down the benign tumors, the most of them had meningiomas, which were around 37%, followed by schwannomas and pituitary adenomas and kidneyophanciomas. Among the malignant tumors, the most common was gliomas, which included the low-grade gliomas, high-grade gliomas, brainstem gliomas, GBM, followed by brain mets, which include single brain mets as well as the multiple brain metastasis. For vascular malformations, most of the patients had arteriovenous malformations followed by cavernoma and glomus tumors. Majority of the patients with functional disorders had neuralgias. Majority of them had trigeminal neuralgias. A few had facial neuralgias as well, and followed by essential tremors, and only one patient had Parkinson's disease. So at our centers, most of the patients, we equally utilize both the techniques, mask and frame. And same goes with the fractionation breakdown. We almost equal patients were treated in single fractions and multiple fractions. And among the patients who were treated with multiple fractions, majority of them were treated in 5 fractions, followed by 3 fractions. So the mean dose delivered to the patients was, the mean volume of the disease was 18.3 centimeter cube, and the mean dose delivered was 25 gray. So out of 500 patients, we only had follow-up of 93 patients because we see patients from all across the country. So it is very difficult to follow those patients, and most of them, they don't appear for the follow-ups. So we only had 93 patients for follow-up. The mean duration of the follow-up was 5.5 months, and the range was 2 to 11 months. Out of those 93 patients, the disease was controlled in 91 patients, and there was complete response in 2 patients, partial response in 67 patients, and the disease was stable in 22 patients. Only 2 patients had disease progression, and they were gliomas. And in patients who had complete response, one of them was meningioma, and the other one was pituitary adenoma. So our initial experience suggests that SRS using gamma knife is a safe and effective technique for brain lesions and disorders. However, a longer patient follow-up is required to draw any meaningful inferences from the available data. Thank you so much. So this is our center. Whenever you come to Karachi, please do come to our center. Thank you.
Just to set the record straight that, as Dr. Atif said, there are no machines currently doing SRS in Punjab, so this is not correct. It's not necessarily that you have the same equipment like cyber knife or gamma knife, but we have DNAG-based SRS at Shaukat, Khanum, and it is much better, or I would say it is certainly better than any other machine that osteopathic.
So when
we do treat patients from last 3 years, we are treating patients on DNAG-based radiosurgery at Lahore.
That's excellent. When you have that equipment, Dr. Kadalla?
It's over 3 years.
Last 3 years.
What is that machine?
We are treating that with the tube with HD MLCs and 6 drop pulse.
You only
That is the only machine in Pakistan with high definition MLCs with 1 millimeter accuracy.
And also there is a machine in Khurki as well, cyber knife. Yeah.
They are also
machines. Yeah.
Okay, but certainly I think you're still treating quite a few Punjabis, is it right? From Punjab as well.
Yeah,
So,
yeah, most of the.
When I was looking at your data, your the population from Sindh was on second number as compared to. So what was the reason for that? Because it seems that the maximum number of patients are.
Well, I don't have an answer to that, but I believe that the Punjab is the most populous province. Yeah, that's the reason.
Here is the other reason. In Sindh, they have 3 gamma knife machines. In Punjab, no gamma knife.
Okay.
So that's why we are getting more patients from Punjab.
And in Sindh, it's been divided down.
I think there is another reason as well, because the indications for gamma knife are very stringent, and in most of the centers where they are taking bulk of patients for cancer and malignancy, they will not treat these patients. As Dr. Atif said, that their number 1 indication was gliomas, and I just have a little my rights, like comments are reserved on that, because in gliomas there is no indication, and it's upfront radiosurgery is not indicated, and then it's not included in any of the guidelines. So any that such patient who comes to us, we will not be treating that patient. So maybe that is the reason, because we don't offer this, out of guidelines.
Yeah, we are quite selective in it actually.
Yeah, that is the main
Diomas
reason.
I am not doing, only I am doing if there is no other option.
Yeah.
And that is basically
For
legal
example,
gliomas.
yes.
Yeah, you
gliomas
can-
are grade
So
one,
any
very
specific
good
reasons you
example.
guys are doing dialysis?
Yeah, most of the patients that come to us, they come after definitive chemoradiation. So, and they also have received the salvage chemotherapies. So they don't have any other options other
They
than,
had all the options.
yeah, they have burned all the options for that, yeah.
Okay, very excellent. Well done.
Yeah.
Any other questions? Ji, please.
Thank you, Dr. Mancha. I just have one question. The pituitary adenoma patient who had CR, what was the dose fractionation?
Well, I don't remember now, but that patient had Cushing syndrome. And most of the Cushings, they are very small in size as compared to polycinomas and other pituitary tumors. So I believe that was the reason.
Right.
The
so-
size, the dose, I don't remember right now. Okay. Yeah.
And dose prescription is to which isodose line?
It is at 50% as dose line. Yeah.
Can I reply to this?
Ji, please.
For pituitary adenoma, there are two types, secreting and non-secreting. For secreting, we give up to 25 milligrams. Again, it depends how much close it is from the optic apparatus. Then we have to fractionate. If it is touching, or it is less than 2 millimeters, there is no space. Then we have to give fractionation.
Yeah.
And for non-secreting, 16
Okay, any other
with
questions?
50%.
Any other questions? So again, an excellent presentation from Dr. Atif Panchal. You had almost 500 patients in the
Yeah.
presentation.
Thank you.
Thank you. So I think we'll conclude our session here. So thanks for the participation and thanks a lot for all the presenters as well for the hard work.